In this tutorial we're going to talk about the most prevalent and most overlooked type of headache, tension type headache. But we're also going to talk about the most severe but quite rare headache, cluster headache, and other so-called trigeminal autonomic cephalalgias or TACs. The first slide here shows you tension type headache, the criteria that are distinguishing tension type headache from migraine. So it's very easy because the pain characteristics are just the opposite. So it's usually bilateral, usually pressing or tightening, usually mild or moderate, and usually not aggravated by physical activity. 2 out of 4 characteristics. Just like in migraine, you had 2 out of 4 pain characteristics. And when it comes to associated symptoms, it's quite easy because in tension type headache, there's normally no associated symptoms, but there can be some photophobia or phonophobia. It's permitted to have one, but not both of them. And at the bottom you see that we subdivide tension type headache according to frequency. It's actually more or less the same phenotype of the attacks, but it's according to frequency. So infrequent tension type, less than once a month. Frequent, between 1 and 14 days a month. And this is a very wide span, and there's a huge difference, in my opinion, between patients who have frequent episodic tension type headache with 10 or 14 days a month, and people who have it and they have only 1 or 2 times a month. So in fact, there's something to consider for a new classification committee because this is too wide a span in my opinion. And then we have the chronic tension type headache patients who have headache on 15 days or more per month, more than half of all days. They were separated out already in the first edition of the headache classification because we realized that tension type headache is so common, it affects 70% of the population. There's no way we can gain any acceptance of tension type headache as a disease in general. But if we single out a severe end of the spectrum, namely chronic tension type headache, maybe that can be taken serious by doctors, authorities, and so on. And maybe that could then stimulate more research in this disorder. It has only partly proven to be true because this is still a disease that is very much neglected, and worldwide there's still very little research being done in tension type headache. In the next slide, I show the actual diagnostic criteria for frequent tension type headache. It's in a way repetition of the previous slide, but here it also mentions that there must be at least 10 episodes in order to make the diagnosis. And this is because it's a relatively featureless headache and often mimicked by secondary causes. The duration is a very wide span, so it's really quite atypical and not very useful as a diagnostic criteria, spanning from 30 minutes to 7 days. And the rest is like the first slide. When we then move to chronic tension type headache, it's again more or less the same phenotype. Now 15 days a month or more. And this is probably about 1 or 2% of the population, so it's still a hugely prevalent disorder. But we don't see them much in the headache centers or even neurology practice. People live with this daily headache. They've given up long time ago to get any relief, and they can function. Most of them can function despite their headache, but it's just causes a lot of impairment to their quality of life. For chronic tension type headache, it's permitted to have mild nausea. It wasn't permitted in episodic tension type headache. And that's an experience that as tension type headache becomes more and more frequent and gradually becomes chronic, some patients do develop nausea and some migraine-like episodes. The basic mechanism underlying tension type headache are largely unknown, but we know that tenderness of chewing muscles and neck muscles, what we call pericranial muscles, is an important factor, and we subdivide both the episodic and the chronic tension type headache into a form with abnormal pericranial tenderness and a form without abnormal pericranial tenderness. The former is by far the most common, but there is a relatively small group of patients who have otherwise typical tension type headache and no pericranial tenderness, and we have no idea what the mechanism is in those cases. We know something about the tender areas that were discussed because the pressure response curve, stimulus response for pressure, is a straight line in the tender spots, but it's a curved line normally. So there is an abnormal, not only increased sensitivity, but also an abnormal stimulus response curve in the tender spots. But what the mechanism is of these tender spots, nobody really knows. And there's been lots of reports about exciting findings, and they've not been reproduced. Now we move to the TACs. Cluster headache, paroxysmal hemicrania, short-lasting unilateral neuralgiform headache attacks, hemicrania continua, and probable trigeminal autonomic cephalalgia. Cluster headache is perhaps the most severe kind of headache that we know of. They have to have 5 attacks. It's a very severe to severe attack. They are shorter lasting than migraine, 15 to 180 minutes. And they have either autonomic symptoms, such as conjunctival injection, lacrimation, nasal congestion, rhinorrhea, eyelid edema, forehead and facial sweating, or sympathetic palsy with meiosis or ptosis, or they have a sense of restlessness or agitation. In most cases, they have all of them. The frequency is much higher, of course, than migraine, so they have from 1 attack every other day to 8 attacks a day. And it's subdivided into an episodic type and a chronic type. And the episodic one occurs in certain periods called cluster periods, and then in between the patient has no headaches at all. And the chronic ones, they have it more or less all the time. They can have short remission periods, but they cannot have remission periods that last 3 months or more. Then they are episodic cluster headache patients. And of course the natural history is that people start with episodic and gradually becomes chronic, but there are also, in rare cases, another sequence of events starting with chronic and going to episodic. The paroxysmal hemicranias are short-lasting attacks, which are otherwise similar to cluster headache, but they are shorter lasting, they are more frequent, they are more common in females, and they have an absolute response to indomethacin. And this is one of 2 examples where we use response to a drug. We usually don't like to use this as part of diagnostic criteria. In the old days, it was suggested to include response to triptans in the migraine definition. Now we know that triptans don't work in at least 1/3 of the patients. So it's very good that we never included response to drugs. But here it's necessary in order to distinguish paroxysmal hemicrania from cluster headache. Then we have SUNCT and SUNA, short-lasting unilateral neuralgiform pains, and these are even more short-lasting than the paroxysmal hemicranias, but there's some overlap in the duration of the attacks. But here it's pain like stabs or a sawtooth pattern, which is different from the pain in the paroxysmal hemicranias. Otherwise, they have the same autonomic symptoms. Some people like to distinguish SUNCT and SUNA. Some people believe that they are just more or less the same. The SUNA criteria include actually the SUNCT patients, but they are still distinguished in the headache classification. The last TAC is hemicrania continua, which is a continuous or at least longer lasting headache, always on the same side, with exacerbations that include autonomic symptoms of the usual kind. And also here, absolute response to indomethacin is necessary in order to distinguish this headache from, for example, a severe unilateral tension type headache. It was previously not in this group, but because of these exacerbations with autonomic symptoms, it was included in the TAC group. So this was a fast trip through all these exciting and devastating headaches actually in the TAC group. And thank you for your attention.